name is Paul Romiser, and I'm pleased to be here on behalf of the Anal Cancer Foundation to talk to you about recurrent and metastatic anal cancer. I'm an assistant attending on the gastrointestinal service in the Department of Radiation Oncology, as well as attending on the early drug development service in the Department of Medicine here at Memorial Sloan Kettering. These are my disclosures for the talk today. Anal cancer is a rare cancer with just under 10,000 cases expected in 2021, representing a 7% increase over the year 2020. Cancer is more common in women than in men. And unfortunately, about 10 to 20% of patients will present with metastatic disease. The most common sites of involvement are the liver, lung, as well as extrapelvic lymph nodes. In addition, about 25% of patients previously treated for stage 3 disease will ultimately develop distant metastatic disease recurrence. And also, about 25% of patients, again with stage 3 disease, will develop locally recurrent disease within the anus or rectum. Let's start off today by talking about locally progressive or recurrent anal cancer. Again, this rate's about 10 to 30% of patients will have either tumor persistence or tumor recurrence after definitive treatment. And here, as you previously heard from Dr. Goodman, definitive treatment often involves chemoradiation. We see higher recurrence rates are associated with higher tumor stage or T stage, which essentially means larger tumors, as well as higher end stage or nodal stage, which means more extensive lymph node spread. In patients who develop recurrent anal cancer, it's important to work them up and evaluate for distant metastatic involvement, because it may change our clinical management of the situation. Patients with persistent or recurrent anal cancer, often surgical salvage is the recommended treatment. So here, if the disease is truly located to the anus, rectum, or lymph nodes in the pelvis, patients may be candidates for radical surgery. The surgery type here is often called the abdominal perineal resection, which includes removal of the anus and the rectum, and the formation of a permanent colostomy. Oftentimes, as these patients have had prior chemoradiation, wound healing problems are an issue here. So the surgeon may talk to the patient about what's called a flap reconstruction. This is where normal healthy tissue is brought into the surgical field to help decrease wound complications and ensure adequate healing. In patients who have involved inguinal lymph nodes or lymph nodes in the groin, oftentimes an inguinal lymph node dissection will be recommended. Here, if the patients had prior radiation or chemoradiation therapy, the risk of lymphedema or swelling of the leg is increased. It's something that the doctor will talk to the patient about. In patients with metastatic anal cancer, oftentimes the recommendation is for systemic therapy. Now, given the rarity of this disease overall, we have limited data driving our recommendations. Fortunately, research in this area is expanding and helping us address these critical questions. And you're going to hear about this from Dr. Ng, who's going to talk next. The first-line treatment for patients with metastatic anal cancer currently is chemotherapy. This can include carboplatin or 5-fluorouracil as the primary option, or other options such as chemotherapy regimens called full cis, full fox, or modified DCF. Some of these we'll talk about today. The second line treatments for patients who have progressed on chemotherapy is currently immunotherapy. Let's talk first about the data behind the recommendation for systemic chemotherapy. This is the INTERACT phase 2 trial, which looked at a total of 91 patients with untreated advanced or metastatic anal squamous cell carcinoma. On the left, you can see patients were randomized 1-to-1 to receive either carboplatin plus paclitaxel or cisplatin plus 5-FU. Here, the overall response rate was similar between the two regimens, 59% with carboplatin plus paclitaxel compared to 57% with cisplatin plus 5-FU. On the right, you can see the waterfall plot where the change in tumor size is depicted as a percent. So when the tumor shrinks, the bars will be negative. And in general, a response is deemed as a 30% or greater shrinkage in tumor size. So you can see that the majority of patients on both of these regimens had a good response to chemotherapy. Carboplatin plus paclitaxel showed lower toxicity compared to cisplatin plus 5-FU, as shown here, where I have the rates of grade 3 or higher toxicity. A grade 3 toxicity is generally toxicity where you require an intervention, such as starting a new medication to address the side effect. A grade 4 toxicity is a toxicity that generally requires hospitalization. And a grade 5 toxicity is a patient death. Fortunately, on this trial, there were no grade 5 toxicities. Here we can see that the most common side effects of this treatment were fatigue or tiredness, mucositis or irritation of the mucous membranes, nausea, thromboembolism or blood clots, all of which were lower in patients treated with carboplatin plus paclitaxel. Another common side effect identified here was neutropenia, or having a low neutrophil count, which can increase your risk of bacterial infection. Here, this rate was lower with the cisplatin plus 5-FU arm. All in all, serious adverse events, and by that I mean a toxicity that was specifically attributed to the chemotherapy, was lower in patients treated with carboplatin plus paclitaxel. Given this, the NCCN recommends carboplatin plus paclitaxel as first-line therapy in patients with metastatic anal squamous cell carcinoma. There are other options that are also effective that can be considered on an individual patient basis when considering pre-existing medical conditions and overall state of health. Here, an alternative first-line regimen is full cis, which is 5-FU, leucovorin, and cisplatin. Here, the cisplatin is at a lower dose than that used on the INTERACT trial that I previously showed you. The overall response rate here is 48%, and the significant grade 3-4 toxicities include neutropenia, anemia, fatigue, and dehydration. Let's move on to second-line treatment options, which now include immunotherapy. Immunotherapy are medications that modulate your immune response. In essence, they activate your immunity to target the tumor in your body. So they're using your own body as the weapon against the cancer. Here in the KEYNOTE-028 study, which was a phase 1b study evaluating pembrolizumab in solid tumors, there were 24 patients with anal squamous cell carcinoma included. And among those patients, the overall response rate was 17%, as shown here in the waterfall plot on the right. The median duration of response was 3.6 months among responders, and treatment here was well tolerated with low rates of grade 3 or 4 side effects, and again, no grade 5 toxicities. More data suggesting the benefit of immunotherapy was from the NCI 967 trial, which was a single-arm phase 2 trial of a nivolumab in 39 patients with anal squamous cell carcinoma who were previously treated with at least one line of systemic therapy. Here, the overall response rate was 24%, as shown on the waterfall on the right, with a median duration of response of just under 6 months among responders. Treatment, again, was well tolerated with low rates of grade 3 or 4 toxicity, and again, no grade 5 toxicities were appreciated. So in conclusion, anal cancer is a rare cancer, making randomized trials difficult. But we're making a lot of progress here, and you're going to hear about that next. Surgical salvage is preferred for locally recurrent disease. Chemotherapy is the first-line standard treatment for patients with metastatic disease. Response rates are on the order of 50 to 60%, and adverse side effects on the order of 33 to 50%. Immunotherapy is the current second-line treatment standard option. Response rates here are about 17 to 25%, with adverse rates of approximately 10%. We certainly need more innovative research to identify new therapeutic regimens for this patient population. Thank you very much.